Thanks for showing up at the early industry sessions. I'm Brett Crist, and we're going to go over CurvaFix, and the faculty for this is Julie Switzer, Daniel Bravin, and Chip Routt is joining us remotely. And so this is the agenda for the morning. I'm going to go over the technical details of the implant and some early data that we have. And then we'll hear from Dr. Routt and Dr. Bravin on some cases. And then Dr. Switzer is going to talk about kind of just especially geriatric fractures in general and how the system is failing us, at least in the United States. And I don't think we're that abnormal from other countries. It's good to see familiar faces. Yeah. All right, so CurvaFix allows you to fill curved corridors and provide strong fixation. So it's I would say one of the few implants that's actually adaptive to the individual patient's anatomy and allows for safe passage. It does allow for early weight bearing, and I actually haven't had any of them back out. It's been kind of an interesting journey in using it. Because I have personally noticed a difference. So the adaptive design, somebody mentioned we had a kind of information meeting last night about some research that we're doing. And one of the things that we don't want to miss is kind of having everybody understand the design of it and how it makes it a rigid implant after you get it in. And so basically there's a 7.5 and 9.5 millimeter diameter option. The interlocking components, as you can see, is from basically how the metallic components are, and then the internal compression device that you can see partially here, and I'll show you some other parts of it that make it a rigid implant once you get it in. But there's a self-tapping design for the threads and the front cutting end, and then it's a stainless steel device. And there have been some removals, and including a couple of broken ones, but the removal process hasn't been a significant problem. I've taken one out, and the cables kind of stayed together to get it out. But this is how it becomes a rigid implant. So there's 4 cables that are similar length, and then when you become in the rigid state, when you lock it, the cables provide compression. And one of the things that you have to get used to is actually the implant will get some compression in that fashion. So it will shorten up some as you compress it to lock it. But this is just a diagram showing some of the, flexibility in the design. And that's one of the things that kind of made me think about using it is getting around implants that are indwelling already, especially in the sacrum. But it allows you to have a little bit more freedom for your starting point as well. So compared to straight versus curved implants, obviously if you're using a straight rigid implant, you're not as flexible or have as many options as something that curves and follows the corridor basically. And so there has been some biomechanical data that shows that the pullout strength is significantly higher than both 6.5 and 7.3 millimeter cannulated screws. And you could see, 715 newtons versus the closest one is 503. So just some updates and some kind of background. So it was designed by Dr. Meek, who's actually here, if you want to talk to him afterwards, to get his thoughts and why he thought it was important to kind of bring this to fruition. It's been in use since 2019. There's over 125 surgeons using it currently, and I'm sure that's going to add as the time goes on for sure. It's used in over 85 facilities. And we are kind of looking at trying to get safety and efficacy data, especially in geriatric pelvic fractures. And so if you have any interest, if you start using the implant and want to contribute to both a prospective and there's a retrospective arm of the study as well, please contact me. Obviously, you can get me through the OTA or just come up to me afterwards. So to date, the implant breakage is 0.3%, 1.3% for removal and revision, loss of fixation 0.3%, removal or revision due to loss of fixation 0.3%. So all of these are very low. Longest time to implant removal is 2 years. So that's a pretty long time. It's not like you're taking these out at a year if you're going to take them out or at least that's what's been done. And typically in geriatric patients, I don't take them out, I just leave them in. So this is the implant removal at 2 years due to sacroiliac pain. And this is kind of the indication where I would take it out is if I'm using it in somebody young. I take at least have a conversation in all the patients that are under 65 that have iliosacral screws, at least talk to them about taking the implants out because I think it does increase the stress on the lumbar spine. But they got it out at 2 years after surgery, and it was removed in less than 20 minutes. And with each kind of iteration, the removal tools are getting easier to use as well. So over 500 patients have 1 year post-op follow-up. This is time from surgery just to overall, as you can see, most of them are less than 12 months or 1 to 2 years. There's a few, 3% at 3 to 4 year. Utilization in the elderly and fragile bone patients or osteoporotic patients is increasing, which oncology is included in that. This is the implant locations. So 50% in the ilium and sacrum, pubic or anterior pelvis, 35%. The LC2 corridor is 5%, and the acetabulum is around 10%. And we'll see some of those cases today. It is kind of mostly used in nonlinear pathways, and most pelvic corridors can accommodate the 7.5 or 9.5. My personal use, I've used the 7.5 mostly in the front of the pelvis, which makes sense. It's a smaller corridor than most posterior corridors. But these are some case examples of different pathways that are curved and or nonlinear. I think it's also very helpful in people with sacral dysmorphism or abnormal kind of baseline anatomy. But here's some early data that's actually at the new techniques and emerging evidence section here. That 3 of us combined data from 3 centers. And you can please take a look at the poster for more specific details. But we had 111 patients at 3 centers, 90 or over 80% were made weight bearing as tolerated, which the goal is to do that, especially in geriatric patients where weight bearing them is tolerated right away. Over around 50% were unassisted at most recent follow-up for ambulation. Less than 10% complication rate. There were 2 malpositioned implants, 1 broken implant, and 1 bladder injury. And then postoperatively, 2 nerve palsies, 1 wound breakdown, and 2 infection. And no, besides the implant that broke, no loss of hardware failure, loss of reduction. So with that, we'll transition to have Dr. Routt present. He's remote here. But obviously, he needs no introduction. He's at Houston. Thanks for joining us, Chip, and we look forward to hear what you have to say today.
Thank you. I'm happy to be there. I wish I could be there to acknowledge Dr. Meek one more time. This is an idea that he had that, I think a lot of people have ideas, but getting them, all the way to where they need to be and in the hands of clinicians is a really important thing. This is where I am today, and I wish I was with you guys. If y'all saw what I was doing today, you'd be very, very sad. I also want to tell you, I just saw a patient with one of our CurvaFix patients yesterday in the clinic, and he's at his 3.5-month anniversary after his surgery, and he's returned to work as a heavy laborer despite his colostomy bag. And I actually released him. I forgot about the study, and so I'll make sure when he comes back to get his bowel hooked back up that we get the 1 year follow-up that you want. So I'm going to stick to just discussing 2 patients today. And these are both acute fractures. One of them, I think, is just a great indication for CurvaFix, just to sort of emphasize what we could and can and should be using it for. And then I'm going to present another patient where I really wish I would have used the CurvaFix. I think I had a real missed opportunity, but we'll get into that. Our first patient is a 28-year-old. He's in a car wreck, unable to walk. He describes his pain 9 out of 10. I think y'all all know these patients. He won't move in the bed or do anything as long as he's perfectly still. His pain is about 6 out of 10. He's hemodynamically stable and otherwise normal. And this is his AP film. And on the AP film, you can see his sites of injuries. You can see he's in a binder, and the binder is revealing the sites of injury even better. The binder is revealing the displacements, and the binder is probably causing the displacements and showing you what's unstable. When the binder's removed, he gets this so-called rebound reduction, not a perfect AP film, but you can still see his sites of injuries. And then the surface renderings with the contrast are always very beautiful imaging, but sometimes they cover up the pathology. So you can see the iliac vessels on the left cover up the sacral injury somewhat, but if you notice, you can also see his communicating vessel from his iliac system to his obturator system, really a beautiful example of that. And then you can see not a lot of deformity when he's not in the binder as a result, but again, obstruction of the surface renderings by the contrast. You can see he's probably the skinniest guy in Houston, Texas, and not much of a sacral injury. You can see where it collapsed in the anterior portion of the cortical bone. And then as we track down, you can see his second sacral segment, and also the dorsal cortical injury is really not much of an injury. You'd anticipate that perhaps this patient could be treated without operation. He would beg to differ with you. On the axial images, as we track through the hips, you can see the contrast enhancement of the vessels and also not much deformity. There's this communicating vessels seen beautifully on the CT scan. And then the superior ramus comminution, inferior ramus displacement. And so we're left with this patient in this situation, but we would offer him the chance to mobilize, and he's going to refuse. He won't get out of bed. He won't move in the bed. And so we offer him this opportunity to be stabilized and reduce somewhat. This is his stable side on the right, and then you can see we already know this. We do this for teaching purposes, but we don't have to do this exam. This is just 5 to 10 pounds of manual pressure on his iliac crest, directed toward the midline, applied bilaterally, and you can see the instability gets revealed as a result of this, just like for the binder. There's so many different options you can use for treating patients. We opted to stabilize the sacral fracture with several iliosacral screws that were directed to accommodate the pathway. This was his soft tissues on his flank. And so when you see soft tissues like this is not a insignificant injury, and you may want to change some of the things that you do. We opted for, I don't know what y'all call this, but a ramus screw, a superior pubic ramus screw that's put in from the supraacetabular area toward the pubic ramus. We call this an antegrade ramus screw. And we use a 2 millimeter Kirschner wire to make sure we're in the right spot on the skin and we get the right direction to the bone and that we're anticipating where we're going. And then I just usually use a 4-5 cannulated, calibrated drill to prepare the pathway. But I think you can see on the inlet view, we're in a little bit of trouble if we're using a straight implant. Now, I would challenge this and just say if I would have just oriented my hand a little bit differently on the obturator outlet image, I could have made this pathway work for a straight implant. And if I'd have started more anteriorly, I could have made this implant work. But as y'all know, I hope you know that this pathway of bone in the area of the anterior wall is extremely narrow and risks the screw being in, or just out. And for this reason, that's why we start where you see the drill, and why we don't start where you see the black arrow on the inlet view is for that very reason. So we're faced with this problem. This is the guide for the opening reamer, or for the initial CurvaFix opening reamer. And we've just put that guide into the 4-5 pathway that we prepared. This is the opening reamer that's put through the percutaneous wound. And then this is the ball tip guide. And you can see we can curve it at its tip to put it where we want it to go in the medullary pathway. And then we can ream and prepare this area to make sure that the pathway is prepared for the device. We can use a switching tube. You can see on the left side and on the right side, the radiolucent, almost radiolucent switching or exchange tube that allows us to put you can see on the left, the ball tip guide, and exchange it for a device passing, just like you might do for a femoral nail. And then you can see we get a length measurement. and then just apply the device. And this is the 7.5 millimeter diameter device. And we sort of get to this crucial point on the inlet view where you can see the device needs to make a turn, and it makes the turn just following this pathway that we prepared. And then, as Brett pointed out, Dr. Crist pointed out, this is the self-tapping edge just burrows its way through the pubic tubercle to nestle into a nice reduction and nice accommodation of the pathway. So postoperatively, as I think you all know, these patients. We know these patients. His comfort after surgery is now a 1 out of 10, and he actually was discharged to home the next day. We kept him for 24 hours of antibiotics, but sometimes these patients go home that evening. We like a CT scan to assess our work. I think you can see the posterior portion of the fracture a little bit better. And then where the CurvaFix device is nestled in the superior ramus pathway, just as you'd anticipate it to be, not too long, not too short, but just like baby bear, just right. And then again, you can see if we'd have been a little more anterior, we wouldn't have had any pathway availability for our device, no matter what its diameter, because there's just not bone there. So we like site-specific stability. We like our implants to accommodate the pathways. We certainly like to correct the deformity and then provide stability. These are all the things that we do, no matter what bone or what joint we're taking care of. And then the CT scan shows us where things are and what we did. The other patient I wanted to talk to you about is just one that I wish I would have, I really wish I would have used the CurvaFix for in several applications. And I'll go a little bit quick through some parts of this. Again, this is a plumber. He actually fell about 4 stories through an elevator shaft and was hemodynamically unstable. And you can see this is a really active guy, owns his own business, still working really hard, and actually is addicted to work. He'd make a really good orthopedic trauma surgeon. He's got true passion for his work. You can see he's had a previous spine operation. That's his iliac crest is missing some bone there from the graft, and that's his sacral injury, his ramus injury. And then you can see his left-sided sacroiliac injury is not really apparent, but that's a crescent iliac fracture with a sacroiliac articular injury. And that's where the problem's going to be. I think if I told you I was going to have a problem with this case, you would say, well, something's going to go wrong with the right hemipelvis. That sacrum is really bad, and that ramus is really bad. But what happens to us is our iliac fracture, this left-sided posterior ring, really causes us some problems. And I'll just show you what we did. There's the iliac fracture that you can see there on the lateral surface rendering. So this is the problem where the crescent iliac injury is. And so if we're going to stabilize this, if we try to do a closed reduction, we've got to make sure that we locate our implant, in the unstable piece and not so close to the fracture. But even if we get it right, it's still sometimes, just by the nature of this iliac fracture, it's just close to where the implants insert. And then you can see the ramus deformity here. He had an arteriogram, got an embolization, and was hemodynamically stable after that. So we used closed reduction. We used frame to help get the ramus pretty close. You can see on that outlet view on the right, the ramus is sort of like a Venn diagram, to use Kamala Harris's terminology. It is a Venn diagram, but again, it's a 3-dimensional Venn diagram. And you can see we've gotten a compression. We can see the sacral fracture gap, and so we could watch this on the C-arm as we tighten the lag screw to get a compression reduction. And then we're managing to get through this 3-dimensional tube misalignment to make sure our 7 millimeter screw is inserted between those tubes of opportunity, and then also make sure the screw is bicortical. And then we go to the left side, and this is part of our problem. We end up with this construct, you can see, which I think most of you would think would be sufficient. But in retrospect, I really wish we'd have used a CurvaFix at the second sacral segment level and started it, and I hope you can see my cursor, more anteriorly, and then also this iliosacral screw more anteriorly, and gotten it more on the unstable part. When you look at the post-op CT scan, things are looking pretty good. The sacral reduction on the right looks good. And the crescent, or a 58-year-old guy, we're pretty pleased with this closed reduction. but we were worried about the screw location adjacent to the fracture. Same for the second, and also the second sacral segment screw here, right on the fracture. And as you know what's about to happen, everything looks fine from the ramus standpoint as well. You can see the ramus is, even though it's not a perfect reduction, it's sort of getting through the space of opportunity properly. But again, if I had this to do over, I wish I would have used a CurvaFix in the front, and I wish I would have used a CurvaFix in the back on the left side to enter more anteriorly. And you can see where our frame was for manipulation. And then we could have also used the CurvaFix to even dodge. We could have made that hump and bump a little bit around the implants, the iliosacral screws as well, so that this could have been a little bit more coordinated dance of fixation. And then at 6 days, he's having some pain. You can see he's lost his fixation on his left side mostly, and the ramus screw is disengaged as a result of that as well. Not much change on the sacrum, but significant change on the crescent iliac injury. And so I'll just, we revised this and did open surgery. We removed the iliosacral screws, removed the washers, did an open reduction with him prone, put in some lag screws, put on a plate like you would if you did an open reduction of a posterior iliac injury, and then added some new iliosacral screws. And this is our posterior construct. Exchanged the screws on the right sacral injury, and then remove the ramus screw. And again, this is how we left him. There's lots of points to consider here. He's gone on to have an uneventful post-operative result, but again, it took him 2 surgeries, and I think a lot of people would be uncomfortable leaving the ramus gapped like that. You could always add a frame, but again, you're adding a frame to where you've got this fixation construct. You might have to change that plate screw a little bit if you're going to add a frame. And then the frame, of course, changes their post-operative regimen a whole lot. Anyway, post-op, you can see the implants, and I don't want to belabor the point, but I wish I would have been a little smarter in my initial planning, and I think the CurvaFix on the left side especially would have helped us avoid a second surgery, and could have helped us really fortify the fixation of the left side, make it more precise to where we wouldn't have this fixation failure like we had with the screws being too close to the fracture. Anyway, those are just my 2 contributions to the day, and I'm going to stop my work here, and I'll turn it back over to y'all. And thank you for the chance to speak. I also hope y'all have a great meeting at the OTA. And I want to thank again Dr. Meek for his work on not just his work on this and the idea, but just the drive to get it to clinicians that need it. And that's all of you that are doing the work. So thank you very much.
Thanks, Dr. Routt. Appreciate that. Next, Daniel Bravin's going to talk about some other uses in different patients.
My name is Daniel Bravin. I'm from University of Missouri, and we're going to go over some techniques about the CurvaFix that I've kind of found that have been very helpful. Disclosures, but so this started for me with a couple of problems that I don't have solutions for, and here's a couple examples. And particularly parasymphyseal fractures have been difficult to treat. There's different options for it with anterior column screws, infix, xfix, like Dr. Routt alluded to, or AF. And then I'm not going to show cases of the sacral U stuff for this, but tomorrow there's some cases with that, but particularly focusing on these parasymphyseal fractures. So this was a case, just to start it off, of something that went badly. But this is a 47-year-old female that got ejected from a car. She had multiple injuries, as you can see, some other injuries that got taken care of first, her head injury, her open fractures and everything. But she ended up with an LC1. I think we would all agree that this is an unstable injury. Here's a CT scan going through it. And so this transverse superior ramus fracture. These are just some images, and this is how I fixed it. I thought that this was good enough. You can see the X-Fix pin again for the reduction, but the X-Fix pin in the top 2 images showing how much distraction, and this is after I fixed it, taking the X-Fix pins and stressing the pelvis and moving it with internal and external rotation. And And so she was touched on weight bearing for other injuries, but had a head injury, so she didn't really follow the directions with that. It also affected her other injuries as well. But this is her follow-up imaging. And so this was just a representative case of a problem that I've run into and trying to find a solution for it. So I'm going to show some techniques where the CurvaFix has helped with that. So this is a 71-year-old male, and this is kind of that high energy geriatric trauma that all of us see. He was a MVC, got T-boned on the left side. He had other injuries and this LC1 pelvic ring injury. This was his trauma bay x-ray. This was his x-ray after when we got our formal x-rays, and again, showing his CT scan here. He got his other injuries taken care of, and then he was having significant pelvic pain, couldn't roll over in bed, couldn't get out of bed. So talked to him about fixation and took him to the OR for fixation of his pelvis. So these are some techniques for the anterior pelvic ring and some of the stuff that I've learned using this implant, but it's essentially the same starting site as the anterior column screw, the classic anterior column screw. I use the 4.5 millimeter drill bit to start with the 2.0 wire, just like Dr. Routt alluded to, and then you end up using this bent tip wire, which again is a described technique, but I've started going out of the pectineal eminence or symphyseal bone anteriorly, and then making a curve anteriorly and going bicortical there to help get better fixation in there, but also it almost acts as a buttress then, so that as they roll over in bed, the implant blocks the internal rotation deformity for it. So a couple other tips. The exchange tube, the way this works is you put this guide wire down and you have to mallet the wire out to get bicortical, and then you exchange that wire for a different wire to put the implant in, and the tube can be a little bit annoying. It's being changed with the second iteration, but to get that past the fracture, you have to, just twisting it helps a lot. And then if you want to go bicortical, you need to, I ream out the anterior portion with at least the 6 millimeter reamer to get the threads to engage better, because that's very good bone anteriorly there. And so this is that curve kind of in the front coming out the bone anteriorly to help prevent the problem that we had on the first patient. So I did this bilaterally on him, and here's his 2-week x-rays. And just like a lot of us have seen, these patients, they don't have pain afterwards, which is kind of incredible. You talk to these people after you fix them and they say, I never had any pelvic pain. Once I got fixed, I never had any pelvic pain. And so his tibia hurt him, his femur hurt him, but he never had any pelvic pain. So this is 2 weeks, this was 3 months. Again, no pelvic pain at all. This is another one that was a little bit of a unique situation. This is a geriatric patient, 88-year-old female, fell in her garden. She presented a week later to clinic, and she has a history of a pelvic fracture and a malunion from 17 years before. So this was a unique situation where she already had a deformity, so a straight screw probably wouldn't have worked as well. Again, getting the same starting site, you can use the wire and it can kind of help assist your reduction once you get it in. That's what the top right image shows. And then getting the exchange tube past the fracture helped in this one. And then the exchange tube, you can actually take the wire that you put the implant in and put that wire in at the same time as the bent tip wire, pull the bent tip wire, and then use the CurvaFix implant. And so this was the example of hers. I fixed the other side with it as well for her. She had the parasymphyseal fracture on that side, but she also had a prior malunion and a deformity. So a couple other tips that I've learned using this implant, for the dense bone, whether you're going across the SI joint for a posterior injury or coming out anteriorly to get bicortical, this was a younger patient, younger high energy patient that I used it on. And as I was malleting in the bent tip wire, the wire started to bend. And so it bent a little bit in the pathway, as you can see, but it also started to bend outside the patient because the bone was so good at anteriorly at his pubic symphysis. So what I did is I took the 4.5 drill, put it down to strengthen the wire, and then put the T-handle chuck on the back of the 4.5 drill and malleted it through that, and then I was able to get the ball tip out the front. And then ream out the front again with his good bone, and these are the images of him fixed. This was an LC2 pattern, so that's how he got fixed. So kind of leading into this, why does it matter? These are some of the many papers showing the problems with this. There's a huge mortality associated with this. A lot of the papers are showing now that it's similar to a matched cohort with hip fractures, 20 to 30% mortality rated a year. These people get loss of autonomy, there's prolonged hospital stay, and obviously the economic costs for this. This is a little bit older paper, but again, showing just the economic cost with this. And so if we can eliminate a couple days for these patients or get their disposition home rather than go into a skilled facility, it helps a lot. The other problem that we've been running into is just the complexity of these patients. So they're decreased bone quality, but also they're increasing severity of their injuries. So this used to be these kind of what you think of the low energy geriatric patients, but now these 80-year-olds with bad bone are getting in car accidents, or they're getting more significant injuries that require fixation. So what we do is we have a fragility fracture consult service, and we have a full-time nurse practitioner that's been great. Every single one of these patients that gets a pelvic ring injury, the elderly patients, gets a consult and is seen by her in clinic. Obviously the unstable fractures get operative treatment. We've been trying to develop a protocol with Dr. Crist and with the research committee of how we're gonna manage this. It was a little bit of a hot topic last night talking about this. But in general, we give these patients a couple days. We give them pain control with a goal to ambulate about 100 feet. And then if it's really pretty obvious the ones that can get up and get out of bed and the ones that can't. And the ones that can't get out of bed we talk about fixing, and we let them all weight bear as tolerated immediately, particularly for the geriatric patients. And if they can't get up and get out of bed, then we'll trial non-operative treatment. But the CurvaFix has kind of changed the way that I've started treating a lot of these elderly fractures, and it's another tool in the bag to help these people.
Thanks, Daniel. So there will be time for questions kind of after this next presentation, but happy to have Julie here. She's the immediate past president of the International Geriatric Society, and she's going to talk about how we maybe can help these geriatric patients a little bit more.
Thanks. This is which one of these talks is not like the other. So the previous talks were great in terms of showing the problem for some of our pelvic fracture patients, and also a really innovative, exquisite solution. Like, I think the CurvaFix technology is just brilliant, not just for pelvic fracture fixation, but I actually can envision a lot of other applications for it. That's not what this talk is about. I'll be brief, but what's happened to me in the course of my practice is that when you talk with geriatric fracture patients, what they complain about, or what patients and families complain about, is what happens to them when they're not admitted to the hospital as inpatients. Rather, they're admitted to observation status. And that matters a lot for folks in their recovery and the financial burden of their recovery. So we looked at that and essentially wrote an opinion paper about it that was published in 2020. All the cases that were shown this morning, I think that the indication for CurvaFix was just brilliant. I mean, I think that you can see how a curved implant that then becomes rigid makes sense in those patients. But the population of pelvic fractures in older patients is huge. We as orthopedic trauma surgeons actually don't see most of those patients because most of them are treated non-operatively. And one of our opportunities is to actually figure out in whom these innovative implants are indicated. I know it's heretical in this setting, but I don't actually think of most of our geriatric fracture patients as commensurate with hip fracture patients. Many of them are, but most of them aren't. LC1 fracture patients treated non-operatively, about 30% of them start to use an assistive device for ambulation that they weren't using before. In hip fracture patients, 70% do, and these are folks who were fixed. So we just, I think, have to get our hands around our indications for this technology, because this is regardless of what happens to us. Even successful aging looks like a declination in stamina, endurance, and physiologic reserve. These little bumps are fracture or some other major pathophysiologic event. Anyway, pelvic fractures represent approximately 5% of lower energy fractures in the elderly. And even though we aspire to and talk about folks going home, almost no one goes home. If you have a patient who goes home, that's awesome. But if you actually study these patients, almost no one goes home. And that's okay, because at skilled nursing facilities, they get skilled nursing and physical therapy. But I don't think we should kid ourselves that most of these folks are going to go home regardless of what we do. Or if you study it, I want to see you publish it. Like, where are these folks going? It's not a failure to go to a skilled nursing facility. It's a failure to not be mobile and have your comfort controlled or your pain controlled. As Daniel mentioned, the mortality rate's around 10 to 20%. Of course, in some studies, it's less than that. And in some studies, it's more than that. It depends on the fracture pattern, I think. And a lot of the data we have, there is not a good description of the actual fracture pattern in these folks. We call them fragility fractures of the pelvis, but we don't delineate anterior or posterior ring disruption. And only about 20% receive the kind of care that Daniel was describing in his patients. And that's a real opportunity for us. So as I mentioned, I was interested in understanding what mattered to these patients. I think if you're in the US, you probably have heard of the 3-day rule. And if you're admitted to the hospital, but you spend less than 3 days in the hospital, and you are then discharged to a skilled nursing facility, Medicare doesn't pay for it. And that's a huge financial burden for patients and their families. The difference between the cost of an inpatient stay and skilled nursing stay is about $1,500 on average. But what happens is that many of our patients who have this injury don't meet criteria for admission as an inpatient, but they can't go home. And so they're admitted as an observation patient, and then when they're discharged to the care facility, they end up paying out of pocket for their care. If you stay 3 days in the hospital, Medicare pays 100% of your skilled nursing facility for the first 20 days and 80% after that. There was one successful model. This was from Cleveland Clinic. They only had 12 patients, actually, but what they did was they identified these patients, sent them to a skilled nursing facility directly because their insurance allowed for that. And in these patients, these were non-operative patients, none was readmitted in about a 6-month period. I think that it's great as orthopedic trauma surgeons to think about and execute the best surgical care when indicated in these patients, but we ought not to forget our partners in the care, which are our geriatricians, hospitalists, dietitians, and other folks. Because we may make a difference with our choice of implant that's, 5%, 10%. But if we also ignore that they don't have good nutrition, or if they're not really getting out of bed with physical therapy or having a reasonable attempt at it, I think we're really missing an opportunity. And there are definitely papers out there that show that operative fixation of low energy pelvic fractures makes a difference in terms of mortality. But there are also a lot of papers out there that show that non-operative treatment has somewhat commensurate outcomes. Now, I believe in this technology for certain patients, but I think our challenge is to determine who those patients are or to understand the best indications for the technology. And in the randomized controlled trials, I mean, there's one that's starting in the Netherlands. There's, I think, one in Germany. I know Brett is spearheading studies here in the U.S. I think the most important question has to do with timing. When the decision is made to go from a non-operative treatment course to an operative treatment course, and fracture pattern. You know, fragility fractures of the pelvis are often lumped together as one entity, but actually understanding the fracture in the patient and then deploying the correct treatment is what I think makes our care most powerful and impactful. We did a little study a few years ago on hip fracture patients, and we were just asking patients what matters to them. I won't go into the details, so we'll have time for questions. But when you really ask patients what matters to them, it's their independence, it's their mobility, it's their, and it's whether or not they feel as though their care team is communicating and whether or not they have coordinated care. So I think it's really important to figure out what's the best technology for surgical care in our patients who need surgery. And yet for these patients, it's great to talk about, oh, the patient went home after a day, they went home, they don't use an assistive device. And those are definitely some of the few patients, but there is a huge population of patients out there for whom operative fixation is probably not indicated. And the greater we understand the natural history of the different types of fragility fracture patterns in the elderly, the better we can do at providing best care. Thanks.
Thank you for coming, especially early in the morning for the continental breakfast. So thanks, and I hope you have a great rest of your OTA.